Hello doctors. Today let's talk about an important and clinically most related topic, that is about pleural effusion. Not only in clinicals, in every exam question paper you can see questions being asked about this topic because this is such a common clinical topic. Now let's slowly start about the anatomy and then we will talk about pleural effusion and the pathophysiology and then see the causes of it. Now let's start with some anatomy. What is pleura? Pleura are layers of tissue surrounding the lungs. There are two types of pleura. One is parietal pleura that lines the chest wall and visceral pleura that lines the lungs. The space between them is called as the pleural space. If you see here, this is the parietal pleura that lines the chest wall, the red color. And then if you see this blue line, that is the visceral pleura that lines the lungs. Viscera of an organ, that's why they call this visceral pleura that lines the organ lungs. And parietal pleura lines the chest wall. The small space between them is the pleural space, as you can see here. This is the pleural space. Now let's talk about pleural effusion. Pleural effusion means excess accumulation of fluid in pleural space. Normally in this pleural space there is little fluid necessary for the lubrication of these two tissues. But when there is more fluid here, that is called as pleural effusion. If you see here, between the visceral pleura and the parietal pleura there is lots of fluid. Excess accumulation of fluid in the pleural space. This is pleural effusion. It can compress the lungs, causing symptoms. Now let's see what do we find in a chest x-ray of a patient who has pleural effusion. If you see in this patient, this one is the normal side of the lungs and obviously there is some problem here. Whenever there is fluid, in the x-ray it will appear as white color, but air will appear as black color. You can see here all these parts, near the patient are air, that's why they are black. Just like that, in the patient's lung there is air, so it's black color. But when the lung is filled with fluid, pleural effusion, it turns out to be white. Now what do we see in the chest x-ray? The costophrenic angle is blunted. This sharp one is the costophrenic angle. If you see in this side, this angle is not seen. That's why this is one of the findings in pleural effusion. Next is meniscus sign. If you see here, this part at the top of the fluid, it forms like a meniscus. That's why meniscus sign. And loss of lung fields. Here you can see the lung fields, black color, but here there is no lung fields, loss of lung fields. There are two types of pleural effusion mainly, that is transudative and exudative. Now, this is an latest technology in which pleural effusion can be detected, that is chest ultrasound. Instead of x-rays, in the developed countries they use chest ultrasound. It can show the pleural fluid and the lungs, and you can see also the diaphragm lever. Normally you can to view pleural effusion, if it is very less or the amount of fluid is very less but still causing symptoms, to view those you can do a lateral decubitus x-ray, that is turn the patient to one side so that fluid gravitates down, you can see that easily. But when the pleural effusion is huge, you can see in the AP or PA view itself. Now what is transudative pleural effusion? We all know that near the lungs there are the lung capillaries through which the blood passes. Now in the capillaries, if the hydrostatic pressure is high or if the oncotic pressure is low, then the fluid inside the capillary will go out, causing pleural effusion. Now Let's see how is it happening. This is the capillary and this is a lung. Near the lung there is this pleural space. Normally blood is flowing in this capillary, so I'll mark it as fluid. With the fluid there is also protein. In what do you mean by high hydrostatic pressure? When the fluid inside the capillaries increases, the pressure inside the capillary will increase. That is high hydrostatic pressure. This can be usually seen in congestive heart failures. That is, when the heart cannot pump the blood backs up into the capillaries and the pressure inside the capillaries rises and the fluid seeps out. If you see here, when there is high hydrostatic pressure inside the capillaries, the fluid will go out. Then the fluid goes into the pleural space, causing pleural effusion. This is transudative pleural effusion due to high hydrostatic pressure. It can also be caused by low oncotic pressure. Low oncotic pressure means there is low amount of protein inside the capillaries. Normally, just imagine for this concept, for example, if there are 30 fluid and 6 protein in a capillary. When the protein amount decreases, for example, the protein becomes 3, the fluid, it will also reduce. First the fluid, I said the fluid, there was 30 fluids and 6 protein. When the protein amount becomes 3, the fluid will also reduce. How does it reduce? It just goes out so that it can maintain the amount of protein present inside. 30 is to 6. If 6 becomes 3, then 30 will become 15. So the fluid, extra fluid will go out, causing pleural effusion. That is how low oncotic pressure causes pleural effusion. As I said, high hydrostatic pressure or low oncotic pressure can transfer fluid from capillaries into pleural space. Transfers the fluid. That's why transudative. Here, only you can see here, only the fluid has gone out, but the protein has not gone out. So in transudative pleural effusion, the protein does not come out, but just the fluid comes out. High hydrostatic pressure causing pleural effusion. Example is congestive heart failure, as I said just now. And low oncotic pressure causing pleural effusion is due to nephrotic syndrome, where you lose lots of protein, or in liver cirrhosis where you can't produce protein. So in both cases there are low protein inside the capillaries, causing the excess fluid to go out. For this we just have to treat the cause. You either treat the congestive heart failure, nephrotic syndrome, or the cirrhosis, and the pleural effusion will stop. In exudative pleural effusion, the fluid exits out from the capillaries due to damage in the capillaries. This can be a local cause or just the anatomical breaking of the capillaries. If you see here, this is the capillaries and the lungs and the pleural space. In the capillaries, there is fluid and proteins. When there is break in the capillaries, it can cause both the fluid and the protein to go out, because there is nothing stopping this protein from going out. There is a break in the capillaries which can allow the fluid and protein to go out, and both this fluid and protein go into the pleural space, causing pleural effusion. You can see the lung size is being compressed, causing symptoms. As I said, the fluid exits from the capillaries into the pleural space due to damage in the capillaries. Both fluids and proteins leak out in exudative pleural effusion. Common causes are cancers and pneumonia, damaging the capillaries. For this, we have to drain the fluid as well as treat the cause. However, there is going to be recurrent pleural effusions. How do we work up a patient with pleural effusion? First, do thoracentesis. If you can see here, just make the patient sit like this and you insert the needle into the rib cage, directly extracting the fluid out. You may do this in the clinicals or you can see this. So what do you do with this fluid that you took out? You send it to the lab and ask them to measure the levels of LDH, lactate dehydrogenase, and the protein levels. Now, once you get the result back, check with this Lights criteria. The Lights criteria point 1 says the pleural protein divided by serum protein, if it is more than 0.5, or the pleural LDH or serum LDH more than 0.6, or the pleural LDH is greater than 2/3 of normal upper limits of LDH, this effusion would be a exudative pleural effusion. The main principle of doing this thoracentesis is we want to find out if the effusion is transudative or if it is exudative, because we know that there are different causes for causing this. If a transudative effusion, we know that the cause is something like systemic, like congestive heart failure or cirrhosis. But if the effusion is exudative effusion, we know that the patient would probably have a malignancy or just a pneumonia. So as I said, in exudative pleural effusion, the protein is also going out with the fluid. That's why you can see the pleural protein, that is protein in the pleural space, or serum protein, the protein in the capillaries. When you divide that, it would be more than 0.5, which means there is protein in the pleural space also, more protein in the pleural space also. Just like that, more LDH. So with the help of Lights criteria, we can divide the transudative and exudative diffusions and treat them accordingly. Now we can see let's see the causes of transudative and exudative pleural effusion. Now this is a very important table which you can expect in your questions. As I said, congestive heart failure causes high hydrostatic pressure causing transudative pleural effusion. Liver cirrhosis can cause low oncotic pressure, nephrotic syndrome low oncotic pressure, and peritoneal dialysis, superior vena cava obstruction, mixed edema, and urinothorax all causes transudative pleural effusion. In the exudates, we can see lots of causes: cancers damaging the capillaries, pneumonia damaging the capillaries, pulmonary embolism from deep vein thrombosis can damage the capillaries, diaphragmatic hernia, SLE, sarcoidosis. If you can see the SLE, the antibodies, it is an autoimmune disease. So the antibodies can go and attack the capillaries of the lungs, causing effusion. Sarcoidosis, Meeks syndrome, can read about this in the obstetrics and gynecology, yellow nail syndrome, and the drug amiodarone and radiotherapy. All these can damage the capillaries, causing exudative pleural effusion. Now, when you are in the ward rounds and you did a thoracentesis of a patient who had pleural effusion, and then you see this milky white fluid coming out. Now, what could be the fluid? What could be the cause? Why is that this milky fluid coming out? Now, you should answer this in the comment section, and I will reply you with the correct answer. Now, that was about our important topic, pleural effusion. We read about the transudative and exudative pleural effusion, and do not forget the causes of those. Thank you, doctors.